HealthEd is Australia's leading provider of quality clinical education for doctors and other healthcare professionals. This episode has been made available on Spotify and Apple Podcasts. For free access to the full library of podcasts and to claim CPD for listening, visit healthed.com.au or download the HealthEd app.
I will be speaking to Associate Professor Michael Woodward on the detection and diagnosis of mild cognitive impairment. Associate Professor Woodward, tell us about yourself.
Thank you, David. I'm a geriatrician who heads aged care research and the memory clinic at the Austin Hospital in Melbourne, and have a passionate interest in the better assessment of people with cognitive disorders. I'm one of the 3 honorary medical advisors to Dementia Australia, and I've been on a number of committees that have had a significant input to government and other bodies about the management and the need to better understand and diagnose dementia.
Today we're looking at the detection and diagnosis of mild cognitive impairment. And Michael, I'm going to present a case to you very shortly, but I would suggest that in general practice, there's a range of responses to patients who present with concerns about their cognitive function. We do it either really well, not so well, and even some might choose to want to evade it because it's a very difficult diagnosis to entertain and work with. So let me just present this 74-year-old woman to you. She is Mrs. Chen, and she presents with concerns about her memory. Now, she has missed a few appointments. She repeats the information according to her husband. She has left lights on and is constantly looking for her purse and glasses. She has been well apart from hypertension and borderline sugars. She still pays bills online and can whip up a great feast for her family. She retired from her job as a university academic 9 years ago. A MMSE is performed. She scores 27, including 2 of 3 for short-term recall. These sorts of patients are clearly not uncommon for us. What do we do next?
So I might start out, David, by saying what we don't do. And we don't say, well, what do you expect at your age, or nothing can be done about this, or it's not worth trying to pursue a diagnosis. What we need to do is to work out where we go with further assessment. I would not be guided at all by the MMSE. It's a very crude tool for picking up minor memory problems, or even significant memory problems, and particularly in a person with such a academic background. I would start by getting more history, making sure that her medications are not affecting cognition. For instance, making sure that the anticholinergic load is not too high. But I'd then do a more appropriate cognitive test. The MoCA, the Montreal Cognitive Assessment, or the Addenbrooks. These only take 5 or 10 minutes, and maybe your practice nurse, if you have one, could help out there. These are the sorts of tools that are very good at better assessing initially a person with cognitive disorders. I would be very surprised if her MoCA was much above 23 or 24, and that means that she does have significant cognitive problems. And then the next question is, where do we go from here? Most GPs know to do a range of blood tests, the so-called dementia screen, thyroid, calcium, B12, folate, etc. But then I think you should seriously consider referring, or at least discussing, the patient with an appropriate specialist. So in many cases, most people listening to this podcast will be in metropolitan areas, although I know there's many in rural areas, and it's not too difficult to access a memory clinic or a memory disorder specialist. And that's the next step I think would be the appropriate one to make.
Michael, I had a previous interview where one looks at the things that can be done to improve the health in general, from cardiovascular, mood health, anything that we can do as GPs, we do. And a time frame of up to a year for reassessment before referral was mentioned. Here we have a fairly early referral. And I had heard in a previous interview a longer term time frame. What should we do? Is it a quicker referral because we are here in an urban city, or where do we go?
Look, that's a good point, David. There's no doubt that some people with mild cognitive impairment will remain very stable for a long period of time, and some, in fact, will revert back to normal cognition. Around about 16-20% per year will move into the dementia stage, where not only is memory affected, but there's a loss of function. My feeling is an early accurate diagnosis is appropriate, and then to watch and see how the person progresses. I would always attend as soon as possible to lifestyle factors such as diet and exercise, and make sure that they're keeping their brain active and their social networks up. I would consider the use of a medical food if we're pretty convinced that they've got mild cognitive impairment due to Alzheimer's. Food has got the trade name Souvenaid. It's very helpful in this situation for slowing down cognitive decline and even slowing down the shrinkage in the hippocampi. And you can start that even before specialist referral. But the advantage of a specialist referral is you'll get an accurate diagnosis. We have much better tools nowadays, such as PET scans, and soon there'll be blood tests that, in the right context, can increase our diagnostic accuracy. I don't think it's enough to say, well, I agree you've got memory problems, let's watch and see. I think we need a diagnosis. I mean, the whole premise of medicine usually is to achieve an accurate diagnosis at an early stage and then maybe wait and see, rather than the other way around.
Just trying to contextualize this, we kind of get this feeling in our gut that we're seeing more and more patients with cognitive impairment, Michael. What is the prevalence of mild cognitive impairment? And what about these diagnostic rates? We're going to refer to, say, to you. What's the chance that MCI can be picked up early?
So, David, we're getting better at it. About 800,000 to 1 million Australians have mild cognitive impairment. And there's diagnostic criteria that define what mild cognitive impairment. It's a prodromal stage of dementia. So most people who achieve the stage of dementia have gone through a stage of mild cognitive impairment. Mild cognitive impairment lasts somewhere between 5 and 10 years. Dementia, somewhere between 4 and 10 years. We know that in Australia, there's about 500,000 people with dementia, and they come from the pool of people with mild cognitive impairment. As we said, not everyone with mild cognitive impairment will progress to dementia in their lifetime, but if we have an accurate diagnosis of the cause of mild cognitive impairment, we can work out what their chances are of developing dementia. For instance, if the specialist finds that there's evidence of amyloid, either through an FDG PET, which is now Medicare subsidised, or by even the more accurate amyloid tests, such as an amyloid PET or a CSF or soon a blood-based test, then with the presence of amyloid, mild cognitive impairment will almost always progress to Alzheimer's dementia, given sufficient time. But if we don't find amyloid, we can certainly watch and see. They may progress to a different form of dementia, such as frontotemporal or Lewy body dementia, or even vascular dementia. But there's a good chance that they won't progress, and that's where we would watch them and again attend to their lifestyle factors. So we can achieve an accurate diagnosis of mild cognitive impairment with biomarkers such as MRI and amyloid biomarkers. They're done now by specialists, and they will tell us a little bit more about the patient's prognosis, but also what we need to do now in terms of monitoring and management.
Now, having said this, investigations are fairly sensitive and specific. How do you differentiate between mild cognitive impairment and other non-cognitive disorders that may mimic mild cognitive impairment?
Well, that's again where an accurate diagnosis is appropriate. I can't tell you how many people I've seen where I feel that, firstly, I'm sure they've got mild cognitive impairment. They score poorly on memory tests. They have a history such as the case that you've just mentioned, but they're still functionally independent. They're still paying bills online and sending messages and photos on their iPhone. So they don't have functional impairment. They're significantly cognitively impaired. So they've got mild cognitive impairment. I can't tell you how many of them I thought, well, this is going to be Alzheimer's. And then I've done an amyloid PET or a blood, or not yet a blood test, but some other form of diagnostic biomarker, and they don't have amyloid. Now, some of these will just be in a very early stage. It'll take them years to develop signs of amyloid. Some of them will never develop amyloid, and I don't know what the cause of their mild cognitive impairment is. We don't always diagnose the cause. In most cases, we will, but not in every case. But it's still important to go through the effort to try and find out the cause, because that has a significant impact on management, and we'll talk about some disease-modifying therapies later if we have time. They're going to be game changers, I feel. But also, again, it's a useful conversation. It's useful to then have a conversation with the patient about prognosis. If they've got amyloid and they've got significant mild cognitive impairment, they will develop dementia due to Alzheimer's if they live long enough.
We're now beginning to feel that getting a right diagnosis with those high-powered tools that you mentioned is important. The question is, how easy is it to access an amyloid scan or an amyloid CSF?
At the moment, they're only done in specialist centres. They are difficult to access. It may be with the disease-modifying therapies that they become more accessible, and we can talk about that. But at the moment, if you send them to a specialist or a memory clinic, they'll almost certainly have a glucose PET scan, which is very good, not quite as good as an amyloid PET, but it's a very good marker for the changes of Alzheimer's. So whilst it doesn't specifically image amyloid, it will show you the areas of the brain that are underactive, and they are characteristically distributed in people with Alzheimer's. It's what we call the default mode network, and in particular, the posterior cingulate and the precuneus. If you see hypometabolism there, and you see sparing of the primary sensory motor cortex, then almost certainly that person has amyloid and has Alzheimer's. And that, again, is therefore a diagnostic tool. Now, FDG PETs, now that they're subsidised by Medicare, have become very accessible, at least in metropolitan areas. They are accessible from rural and remote areas, but there's obviously a bit more logistic difficulty there. And we know that before the subsidisation, only a few hundred people a year were having FDG PETs. Now, I believe it's up to nearly 10,000 people, and they only became free a few months ago. So they are being used extensively and appropriately for the diagnosis of Alzheimer's and indeed for other forms of dementia. FDG PET is not specific for amyloid, and it can also pick up frontotemporal dementia or Lewy body dementia, all of which go through a mild cognitive impairment stage. And again, knowing what's going on, I think is very helpful for monitoring the patient, for discussing with the patient prognosis and management.
Could you just say that what you just said again about the fact that this particular PET scan is now available? What is it on Medicare? Is it?
So the big game changer now, David, even though amyloid PET and other amyloid biomarkers such as CSF and soon blood not easily accessible, we do now have FDG PET available and subsidised through Medicare Australia. And indeed, that's caused a huge uptake of FDG PETs. It's gone from a few hundred a year to now, I think, 10,000 have been performed. And there's actually long waiting lists for them. It's a very good test for picking up the changes of Alzheimer's disease. We see underactivity in certain regions of the brain, but it also picks up other forms of dementia, such as frontotemporal dementia and Lewy body disease. So it's the go-to test of most specialists and most memory clinics that can't yet be ordered by GPs. But it's the go-to test to increase diagnostic accuracy. Without a biomarker such as an FDG PET, even specialists are only accurate about 70% of the time in working out what the cause of a person's mild cognitive impairment is. With these tests, the diagnostic accuracy goes up to close to 90%.
I'm going to go and ask a couple of questions now back at this level with the patient. Now, when we're seeing the patient, of course, we need to ask ourselves the questions like, what sorts of history should be included when we take a history at the onset, when we first meet Mrs. Chung, and whether or not there are indeed some screening or testing tools, online self-testing tools, apps. Are they useful or are they counterproductive?
We are blessed now that we do have some online screening tools. One is called the Brain Tracker that's been put out by Dementia Australia. And a person doing a fun series of activities based around travel actually can see how their cognition is and see how it changes. And that can alert them to the fact that either they have a problem now or as it changes, they have a problem in the future. They can actually get a printout of which areas of their brain are working well and which aren't, and they can bring that along to you, the GP, and say, look, doctor, it seems that my memory, my visuospatial function, my executive function has started to decline. I'm wondering whether I need more assessment. That will be, I think, very helpful. But when a person like Mrs. Chen comes along with or without her readout from her online screening tools or her iPhone screening tools, I think it's important for the doctor to spend a few minutes on history and even on examination, and particularly looking at medications. So in the history, I ask about memory symptoms, such as the ones that Mrs. Cheng exemplifies. You can ask other ones, like, if you're watching a movie together, does she keep asking you who that character is or what happened in the last episode? Does she forget what happened last night or a few days ago? Does she forget visits? Does she uncharacteristically now forget to celebrate birthdays or anniversaries? Those sorts of memory questions. There's many more that we can think of. But I also ask about function. Is she still independent? We heard that she probably is. If she's paying bills online. Other questions about independence can include using household utensils, using tools, using the lawnmower, etc. And then I also ask about mood and personality changes, because these can mimic mild cognitive impairment, but can also be features of mild cognitive impairment. In fact, we now think about mild behavioral impairment as something that often goes along with mild cognitive impairment. So has she become more apathetic? Is she a bit more, is she sadder? Is she more anxious? Is she frustrated? Is she more cranky or aggressive? Does she have paranoid delusions? I saw a patient recently who was convinced that somebody's siphoning off electricity from her house, but she still doesn't have dementia. She's in the mild cognitive impairment phase, but she's got this fixed delusion. And is she having hallucinations? I also ask about language function. Is he or she having trouble finding words? Is she struggling in social conversations? And I also ask about sleep, and in particular, is she thrashing around when she's dreaming? Because that's often a prodromal feature of Lewy body disease and associated with that Parkinson's disease. So they're the 5 areas: memory, function, mood and behavior, language, and sleep. That's probably enough. It takes 5 or so minutes to ask those questions. A brief physical examination, all I'm really looking for is gross signs of heart or lung disease, but also neurologically signs of an extrapyramidal disorder. What's the gait like? Do they have a cogwheel rigidity? Do they have a shake? And then we send off the blood tests, such as B12, folate, thyroid function, calcium, usinase. It's not useful to do a CAT scan. They're pretty much a waste of time. They're unnecessary irradiation. If the person's going to go to a specialist, they'll almost certainly get an MRI, which is much more useful and much more accurate, particularly in showing focal areas of atrophy. So that's basically, and also, as I said, look at medications. In particular, look at drugs which have an anticholinergic load, particularly if they're additive. So a person's on a small dose of amitriptyline. They may also be on a small dose of an antihistamine. If you add up, there are tools that can help you with this. If you add up the total anticholinergic burden, and it's significant, then these could also be contributing to a person's cognitive symptoms.
This episode is one of hundreds of informative and free clinical podcasts from HealthEd. Access the entire library through the HealthEd app for healthcare professionals, which you can download today from the App Store.
Michael, thank you for bringing up the antihistamines, because Australia, we have a lot of allergies, and a lot of our antihistamines are over the counter, and we often don't know how long and how often patients might take it. Is antihistamine use cumulative, and how important is it as a cause of impairment?
So the main problem is the anticholinergic effect, but they can also, certainly the older ones, have a sedative effect. Usually alone, they won't cause a syndrome that looks like mild cognitive impairment, but they could, in addition to other medications, be contributing to it. So it's certainly important to ask about those and ask the person if they could try going off them if it seems like they could be a culprit there. But there are other drugs that contribute to anticholinergic burden that we may not actually recognize as such. Drugs such as furosemide and even digoxin all have a slight anticholinergic effect. So it's quite useful to basically put all the drugs into an anticholinergic burden tool and work out what the total burden is.
Where did we find such a tool?
I think they're online. Certainly, Sarah Hilmer is one of the leaders of this, and also David Lakuta. So we might be able to put a link to those tools in the web version of this podcast or on the HealthEd web.
Just listening to furosemide and digoxin, I'm suddenly very mindful of our older patients with heart failure.
And certainly many illnesses can affect cognition. Probably the main ones are those that impair blood flow to the brain. Now, the brain's pretty good at keeping its blood flow up. Its cerebral autoregulation is very effective, but some conditions will reduce blood flow to the brain. Severe aortic stenosis, severe carotid disease, severe heart failure. So it is worth doing a physical examination, and you may well find that their cognition will improve if you can address these problems. I've had a couple of patients who have had their aortic valve stenosis treated, usually now with a TAVI, and their cognition has improved.
Fantastic. So let's now move forward to where we have now got the diagnosis. We've always been told we work as a team. Can you elaborate on the role of the pharmacists and other allied healthcare professionals?
So I think we need to see the management of cognitive disorders, including mild cognitive impairment and dementia, as a team effort. You've got the specialist there in the background to provide the initial diagnosis and maybe some follow-up. You've got the GP, of course, but you've also got primary care nurses who can monitor cognition, do an MMSE, or in the case of MCI, a more sensitive tool such as a MoCA, can do them, say, every 12 months. The nurse and the GP and other online information can be used to help a person modify their lifestyle. In fact, we know from a number of very large nationally based trials that modification of lifestyle can significantly reduce the risk of developing cognitive impairment, and by implication, reduce the risk of people with mild cognitive impairment moving on to the dementia stage. So there's a number of online tools and resources to look at diet. The Mediterranean diet is recommended. Exercise, 40 minutes 5 times a week is recommended as the minimum. Social and mental activity. Treatment of depression, we've mentioned that, but also treatment of hearing loss is another way of improving cognition and reducing the chance of developing dementia. All these can be done by the team. You might have a physiotherapist or an exercise physiologist involved. The pharmacist is really important for making sure that the medications are not contributing to cognitive impairment, but also that the patient is complying. Remember, they're forgetful patients. They may be taking their medicines twice as often or half as often as they should. And the pharmacist should be able to help as part of the team in detecting that. If they give you a call and say, Mrs. Cheng has been on irbesartan for her blood pressure, and by my count, she's only been taking the tablet every 4th day, or perhaps even more worryingly, she seems to be taking twice as many tablets as she should. And then the pharmacist can administer a dose administration aid or recommend a dose administration aid. Pharmacists are also useful in advising about these new nutritional support, Souvenaid. They're available in most pharmacies, and a good pharmacist will at least discuss that with the patient, but your recommendation would also be very useful. So I think we need to see the management of cognitive disorders as a team effort. And this is very much aligned with the 75-year-old health check, because that might be the first time that you detect the person's cognitive impairment. They may not always come to you complaining. You might pick it up yourself.
Michael, I'd like to just expand on some of these lifestyle things you just mentioned. And for some of our listeners who have not listened to previous interviews regarding lifestyle changes in mild cognitive impairment, you've mentioned a few things. You've said that Mediterranean diet's helpful, and there's a nutritional supplement called Souvenaid. Please elaborate.
So the Mediterranean diet is shown repeatedly to be good for the heart, and also now been shown to be good for the brain. In fact, many of the lifestyle changes that are good for the brain are also good for the heart. So it's like the poly pill, but a lifestyle version of it, the poly lifestyle pill, if you like. The Mediterranean diet, which in the cardiovascular realm is called the MIND diet, has been associated with a much lower risk of cognitive decline and progression to dementia. It includes green leafy vegetables and fish as the main source of protein, not too much red meat, certainly not too much fat, and if you do use oil, it should be olive oil, not too much in the way of sweets, nuts, legumes, and pasta are recommended. You can think of it as somebody living in an Italian or a Greek village. They'll eat what's in the veggie garden. They'll throw a line into the river or the sea and catch fish. They won't kill the family cow because they need a bit of dairy produce, so there's not a lot of red meat. They have an olive tree in the background, maybe some nuts nearby. They'll have some access to pasture. There won't be a sweet shop in the village. That's just for the tourists in the large towns. So that's the Mediterranean diet. And the food supplement that we recommended, Souvenaid, has mainly polyunsaturated fatty acids, which are also part of the Mediterranean diet, usually from fish. But Souvenaid has also been formulated to have a number of other components that help the creation of synapses. So it feeds into a metabolic pathway. We call it the Kennedy pathway. It also has uridine and choline, which are important parts of this pathway. And it also has a number of trace elements. It's been specifically designed to help synapses, basically synapses that are under amyloid attack, more likely to regenerate and be healthy if a person is on this particular medical food called Souvenaid.
And you did mention that GPs could prescribe this whilst waiting for the patient to see a specialist.
Absolutely. It's not about a prescription, it's a recommendation. It doesn't need a prescription. It can be acquired from most pharmacies, and the big chains seem to have it at a slightly cheaper price. It can also be acquired directly from the company in Sydney, and they'll deliver it to the door, and again at perhaps a slightly reduced price. So it's really important, if you recommend Souvenaid, that the person does take it every day, and the recommendation is to take it for 3 years once a diagnosis of mild cognitive impairment due to Alzheimer's has been established. The recently published study in a very prestigious journal called Alzheimer's and Dementia showed the greatest benefit occurred after 3 years, not after 1 year, not after 2 years, but after 3 years.
Could you spell it for us?
Souvenaid. It's from the French word souvenir or something like that, which means to remember. Souvenaid.
Fantastic. I would like to quickly touch on the fact that there are several articles I've read point to the insulin resistance that sits behind some of the cognitive impairment. Having said that, could or should a GP talk to a patient about significantly reducing both the sugar load and not such a high carbohydrate diet?
Very important, David. There's no doubt that there is a link between Alzheimer's and diabetes and insulin resistance. People who are overweight or who have a metabolic syndrome are more likely to develop cognitive disease. And that can be Alzheimer's, not just vascular cognitive disorders. So it is important to address that. In fact, some of the therapies that we've been trying to modify disease progression include insulin itself and a number of drugs that we use for treating diabetes. In my research centre here at the Austin, we're using at least 2 of the new anti-diabetic drugs to see if they actually slow down the cognitive decline in people who have Alzheimer's disease. So that's a very important issue to address. Some people call Alzheimer's type 3 diabetes. That's probably taking it a little bit far, but it shows the strong link between dementia and diabetes.
I would like to just quickly mention that a lot of my patients cannot see that eating a lot of rice and breads contributes to a glycemic load and therefore a hyperinsulinemia. What do you say to that?
Oh, look, I think you just have to have, again, a sensible diet, the Mediterranean diet. There's not a huge carbohydrate load in the Mediterranean diet. It's more green leafy vegetables, and fish is the main source of animal protein. I imagine that you have a fairly extensive practice in the Asian and Chinese community, David, and therefore it's rice, in other it's bread, it's pasta. Too much of any of these are not good for the brain and not good for the heart.
I've had a very interesting talk with you, Professor Woodward. I just wonder whether I have missed any important issues.
David, I'd like to talk about these new disease-modifying drugs, the monoclonal antibodies that are on the horizon. One of them, lecanemab, has already been shown in a phase 3 trial to slow down cognitive decline in those with what we call early or mild Alzheimer's. That includes mild cognitive impairment due to Alzheimer's and the early dementia stage of Alzheimer's. And the reduction was really quite significant, 28% less decline over 18 months. If you project it out to 2 years, it's likely that you're buying about 9 months less decline. In other words, the people on the monoclonal antibody would be 9 months less advanced in their cognitive disease than the people on placebo at 2 years. And that's very significant. In fact, I think, David, the main goal with mild cognitive impairment is to allow a person to live with their Alzheimer's or whatever other pathology is causing their MCI, to live with it and not to let that pathology dominate their life. I actually say it pretty brutally, I think sometimes. I say our goal is to make sure that you die with Alzheimer's, not because of Alzheimer's. And we can do that to a significant degree with the lifestyle changes we've spoken about, the food that we spoke about, but also these monoclonal antibodies could well have a role here. So drugs like lecanemab and earlier on another one, perhaps not quite as effective, aducanumab, were approved for the treatment of mild or early Alzheimer's. I believe they'll be on the Australian market, or at least one or two of them will be within 12 months. And I think that's going to be something GPs need to be prepared for. I don't think GPs were prepared for the disease-modifying drugs for multiple sclerosis. They just suddenly found people who were seeing their neurologists were coming back and they were treated with these drugs, and the GPs didn't know what the drugs were or how they should be monitored or what to look out for. So I think it's really important that if these disease-modifying drugs for Alzheimer's become available, we make sure GPs know what they are, how they work. They remove amyloid, what side effects can occur. There can be infusion reactions because these drugs are given by intravenous or subcutaneous routes. But there can also be a form of brain swelling called ARIA that the specialist will be monitoring for, but the GP needs to know that it's not a stroke, it's not encephalitis. In fact, in most cases, it's a mild symptom. So the side effects of these medications need to be understood by GPs at a fairly early stage. I don't think we want to go down the route we went down with the disease-modifying drugs for MS, because even me as a specialist, I didn't know what was happening there. I just suddenly found patients coming to me on these drugs. Well, I don't want the same to occur when these disease-modifying drugs for Alzheimer's become available, and I want GPs to be well informed about them. But also, these drugs are going to drive a great desire by patients to be assessed by their GP. They're going to come and say, I want this drug. I've got memory problems. So the GP needs to be able to work out, is their memory problem significant? Do they need a specialist assessment, etc.?
You've mentioned that the amyloid PET scans or the availability, of the FDG PET scans is a game changer for diagnosis. This sounds like a game changer for treatment.
Oh, absolutely. But one thing which is interesting is to get these drugs, these monoclonal antibodies, people are going to have an amyloid PET scan, although maybe later on blood tests will be a substitute for that. And so as part of the submission to the PBAC, the people who are eligible for these drugs will have a funded amyloid PET scan. So I think access to amyloid PET scans through specialists, initially anyway, will also become much freer. So we'll probably find amyloid PETs, which are more accurate for diagnosing Alzheimer's disease. We'll probably find them becoming much more accessible as part of the change in the diagnostic and therapeutic landscape that these disease-modifying drugs are undoubtedly going to lead to.
Let's see if I can get this right. You're telling me that it is very important that GPs latch onto a patient's concerns early, refer early so that we can now get specific and clear diagnosis, because at this stage, lifestyle intervention is really helpful, but there is coming a game-changing monoclonal antibody that will reduce the rate of progression. Your goal is to basically allow the patients to die with the disease and not because of it.
David, if I was marking you, I'd give you 10 out of 10 for your précis of what we've said. You've done a very good job. I guess the only other thing is that management is where the GP sits. So after the initial recognition and sending off for a diagnosis, management is the GP's role with the team. So assessing the patient, ideally, I think every 6 months, reinforcing the lifestyle changes and making sure that the patient is encouraged to adhere to them, checking for the development of diabetes or blood pressure or cholesterol problems, because these can also impact upon cognition, reviewing their medications, and making sure that the patient has good knowledge from sources such as Dementia Australia, and there's another website called Forward with Dementia that I'd also recommend. This is where the GP comes in. And the patient with mild cognitive impairment cannot be managed entirely by a specialist. In fact, we will never have enough specialists to diagnose the million people and to diagnose and manage a million Australians with mild cognitive impairment. The GP is absolutely integral to that.
Professor Woodward, I just thank you for this interview. It has been really interesting and very, if you like, I've just learned so much from it.
Okay, David, good to speak to you.
Donanemab has TGA registration in Australia and is being administered now in most large Australian cities for those with mild Alzheimer's, including mild cognitive impairment due to Alzheimer's.
Thank you for listening. Visit healthed.com.au to create a free account and claim CPD for podcasts like this and access a record of your learning. Subscribe to the show on Spotify or Apple Podcasts for weekly episodes on a range of clinical areas relevant to your ongoing practice.